episode of Anatomical Gangster, the show where we explore the human body through science, stories, and the lived experience of what it means to be alive. I'm your host, Sue Hitzman. If you're new to the podcast, would you do me a favor? Will you please click that subscribe button, follow, and share this podcast with anyone who wants conversations that challenge assumptions and bring clarity to the complexity of being human. Today's guest is somebody I deeply respect, Ruth Duncan, founder of InTouch Education and one of the most grounded, thoughtful voices in modern manual therapy and pain science today. Ruth has become an essential educator for therapists who want to move past outdated narratives, the fascial release myths, the tissue-centric explanations for pain, and the oversimplified polyvagal language, and the polished pseudoscience that seems to be filling my social media feeds today. What I love about Ruth's work is that she isn't here to tear down models. She's here to refine them. She isn't here to make therapy sound magical. She's here to make it meaningful. And she isn't here to hand therapists a new dogma. She's here to help them think. Today, we're going to get her take on a popular topic these days, the polyvagal theory, the myth of fascial release. Does fascia actually release? Branded techniques masquerading as proven science, and what hands-on therapy actually does when it works. We'll also talk about her new book, A Massage Therapist's Guide to Pain, Touch, and Perception, and the integrated hands-on therapy workshops she's running this year. This is going to be a generous, myth-busting, deeply human conversation, exactly the kind we like around here. So grab a glass of water, take a deep breath, and I hope you enjoy this conversation with Ruth Duncan. Ruth, thank you so much for coming back on Anatomical Gangster. It's so great to see you. It's always a pleasure to, just hang out with you for any time I ever have. So thanks for
Yeah,
coming
thanks
back.
for asking.
I love it. That we were just talking, like the last time I spoke with you, I think it was 2022.
Mm.
You had gone back and completed a degree and advanced your education with
Mhm.
neuroscience. And how was that? How is it? And where are you today with those concepts?
Yeah, it was an unexpected change. As I mentioned earlier, I didn't intend to do a unit in neuroscience in my degree. And I thought, as my niece getting hold of me, I thought that I would go back and yeah, I wanted to get some more education. It's always the same thing, I think, in our profession where there's a lot of questions and you can't find the answers. And
Yes.
I thought, you know what, maybe I need to go back to the drawing board. So I ended up doing a unit in neuroscience. It was called Science of the Senses. So it wasn't just about touch, it was about how you can get audio signals, visual signals. And that at the time, I thought, well, I don't want to know about this. I just want to know about touch. But actually, now when you're doing things like bringing in vestibular balance and bringing in eyes and testing eye movements is becoming much more aligned now with what we do in body work. So I did this unit in neuroscience, and in the same year, I did a unit in evidence-based practice. So I finished my degree, I think it was May 21, and I thought, well, I'm not going to stop there. I want to go and do a postgrad. And it just so happened that the University of South Australia were doing a postgrad in pain science and theory with speakers in it like Lorimer Moseley and Tasha Stanton. And I had done a few of the master sessions with Lorimer Moseley through NOI. And I thought, yeah, this sounds good. This sounds like what I want to do. But the lectures were in the middle of the night because they were in Australia. So that was a bit of a drama. But yeah, I finished that and really enjoyed it too.
Wow. I mean, it's really incredible. And I think you're one of those educators where you've been trained from years ago and
Mm,
you're still learning. And I feel the
yeah,
same. It's like, I mean, I still just constantly am reading research papers and updating copy and rethinking the
yeah,
language that I use because we're just
yeah,
learning more and more. And I
yeah.
think that I think I saw on your news feed on Facebook that you had written something about like trademarked programs. And you said
Mm,
that a trademark protects a name, it doesn't prove a mechanism. So for the
Technique,
list,
yes.
yeah, and I love that. So for the listeners who are therapists or students or consumers of bodywork, like what's actually happening when a branded technique starts to get confused with a proven intervention, and how do we end
Yeah.
up here as a profession?
That's a really good question because I can see an argument from both sides. Let's just say, uh, I do a lot of myofascial release, and I trained as a massage therapist in Florida. So I got exposed in my massage training to lots of different styles of practice and the way of doing things that was at the time slightly different to the UK.
Mm,
So I followed what interested me at the time, which was my fascia release. There's a brand, there's a name, there's a head of the skill set, a lead tutor, and I became known for my fascia release, and I taught my fascia release. I teach my fascia release. So for me, there's a name and a brand that the public will go out and look for because they've heard or they've read that the brand is probably going to be something that feels right to them. So they go and look for a therapist who does that brand. And from that perspective, if a client or patient looks for a brand, they're going in with an expectation. And the expectation itself is enough to have a push in towards that therapeutic effect as an outcome. So I see that side of the coin, as it were. But on the other side of the coin, if we keep selling brands, I once had a client say to me, she came in and she looked at all of my certificates on the wall, and I probably had, I don't know, 12 certificates up on the wall because I was really proud of them. And she
mhm,
said to me, "What is it you're looking for?" And I kind of stepped back and I thought, oh, actually, she's right. I've got all of these certificates, but does it actually confirm that I'm good at what I do? It
mhm.
says I've done the training, but I might not be good at what I do. So if we keep putting forward the brand first, if we keep saying, I just do my fascia release works, that's because what I do, that can apply to any brand, then we're putting the brand before the needs of the client. And that sometimes is not the best way to look at it for people. So I do see both camps. I see a reason for one way for one person, but a different way for somebody else.
Yeah, I think that's such an important element there because what people perceive as a
Mm.
technique and what somebody might actually be doing are very different. And I can only
Yeah.
speak for myself. I've had probably up in the range of near 1,000, if not more, hands-on
Mm.
therapeutic interventions from other therapists. I mean, I've traveled all around the world and have had body work sessions with
Mm.
people and people saying that they do a technique and it being
Yeah.
vastly different than this other
Different.
person who's doing it. And
Yeah.
so it's like, did you guys both study with the same teachers? And they're like, yeah. I'm
Exactly.
like, that's a little mind-blowing, right?
Yeah, absolutely, exactly. And that's happened to me too. I remember I was a demo body for a workshop by somebody who was a very well educated and experienced MFR therapist. And she came
Mhm.
over to the UK and I just happened to be the demo body. And she was doing like a very, what I call a bog standard routine cross hand technique. And she put her hands on me. I was like, holy crap, that's really heavy. That's not the way I do it, but she gets results. And I'd experienced that before, but just as you say, people can go to the same training program, but they'll do it completely differently. And that then makes us ask a question, is there a right way for a technique?
Right.
Is it more than just a technique? And of course it is. It's that whole therapeutic relationship. So that then takes you down another rabbit hole, and you say, well, actually, are they really that different? Is craniosacral that different from MFR? Is it different to Bowen? Is that style of massage really different from that style of massage? Because they all have positive outcomes, so they all must be doing something similar. They
Yes.
can't be that different.
That's right. Yeah, I'm going to agree with that so much because I think some people really do like they live in a camp and their way is better
Yeah.
than this way. But
Yes.
again, when you go to a Bowen therapist or somebody does cranial sacral or MFR, there are common threads, and really a lot of it, I don't even think is giving the result that we say the technique is giving.
Mm,
Rather, there's something else happening, and
yeah.
we're not really, digging enough into the process of what
Yeah.
actually is happening in the body when we put
Yeah.
our hands on a client. And quite frankly, even before we put our hands on our client, there can
Hmm.
be a change in the person who walks into the room just
Yeah.
from being with you, right?
Yeah, totally. I've actually got a little bit written in my book, imagine that you're lying face down on a massage table and you've had the most amazing massage. And all you did was you lay prone on the couch. The massage therapist came in, they started doing the massage. It was amazing. The music was great. The warmth of the room was great. It just felt fantastic. And you think, God, that was the best massage I've ever had. And you turn around and there's Hannibal Lecter, who was your massage therapist, and that's going to completely obliterate. I've told that story a couple of times to some classes, and they look at me and I go, "You don't know who Hannibal Lecter is, do you?" And I thought, God, I'm showing my age. And I said, "Okay, what about Vecna from Stranger Things?" And they go, "Okay, yeah, we know who that is."
Yeah, yeah.
But it obliterates the whole massage. And I remember a long time ago, I was down in London and I was doing a training course and I was staying at this bed and breakfast, and the people that owned the B&B actually happened to be massage tutors. And the guy said to me, "When you come back from class tomorrow, would you like a massage?" And I thought that would be great. I'd love that. And so when I came back, he had me. It was in part of the house, and he had convector heaters around the room. And I'm lying face down on the treatment couch. He's massaging me. God, it was so warm in the room because of these heaters. And eventually, I had to say to them, "Could you just turn them off?" And then I became aware of something really weird happening. And he was dripping on me. He was sweating, and he was dripping on me. And he just kept rubbing it in. And I was like, oh my God, that could have been quite a nice massage, but that's not a nice massage anymore.
Yeah,
So
yeah.
there's a whole collection of things involved in that outcome, that patient-reported outcome measure at the end of the massage. It is even down to what the therapist is wearing, the music in the room, the temperature in the room, maybe even some clients like pictures on the walls and other people won't.
Mm,
It's that whole contextual factor that can make such a difference. And for me, teaching a therapist, it's not about the technique, because how many times do you hear what technique is the best for? And there's a
right.
list, and it's just like, God, here we go again. But it's the way you talk to them, it's the way you invite them in the room, it's the way you do the consultation with them. It builds that fantastic story of that whole therapeutic environment. And for some clients and patients, they come in, it's the first time they've actually been heard. And they're actually being able to tell their story, and the therapist is patient enough and respectful enough to hear it, and that's huge. That's huge for some people with chronic persistent pain.
It's so important. And when Carol Davis's book about, just the
Yep.
client
Client
patient
interaction.
interaction. And
Yep.
it really, I have friends who have just finally gone through massage therapy school and then come back to me telling me a story and how like they didn't come back to me anymore and I must have done something wrong. And I'm like, well, talk me through what happened. And it
Mm,
really comes down to also just understanding boundaries and
yeah.
that where you are in your self agency is going to make a huge
Mhm.
energetic pull towards this
Yes.
person. So maybe you got to like ground yourself before you work on clients. And I think
Yes.
that that's a
Yes.
practice beyond the touch that
Yeah.
most therapists don't do. And I do want to talk about your book, but I don't want to talk about it yet. I want to talk a little
Mhm.
bit about, there was actually a post that I saw from you where you were talking about research papers. And when a paper comes out titled The Effects of Something on a Condition, you've
Mhm.
pointed out the brand can become the hero before anybody actually
Mhm.
reads the paper, which I
Yeah.
I I get that too. I mean, I've written I actually didn't write it, but they used melt method in
Mhm.
low back pain, right? But
Yes.
then, you have to realize like this was just one study about one topic with all the exclusions, and
Mhm.
it doesn't claim anything, right? But then people will be like, oh, like it cures low back pain. I'm like, that's not what that study was about. Like, did you read the
Yeah.
research paper?
Yeah.
So what questions should a thoughtful therapist actually be asking when they read a research paper? And what's the difference between an intervention being delivered and a method being proven?
Yeah. That's a difficult one. There's lots of different facets to it. Um, I do see the challenges that a training provider, let me just call them a training provider, has when they try to showcase their intervention as being valuable. It's not suggesting that it's better than anything else. It's trying to showcase its value. So, say, for example, I saw one the other day, it was on reflexology. And for people that don't quite understand research and what it's there for, it's not trying to discredit something. It's actually trying to show what's the value of this and how financially can we actually use this in practice. And in the UK, because the NHS is so heavily involved in finances, it has to be financially viable for the NHS to adopt it. So if there's something that says on reflexology, and it was reflexology, I think it was in pregnant women, and the difficulty is that they had it with reflexology as the intervention in the experimental group, but they had just foot touching in the control group.
Mm,
Now, straight away, there's going to be a difficulty there because any touch is going to be positive. So when you're thinking of an intervention as being able to say, how valuable is it in my clinical practice, you've got to appreciate that it's actually almost reading between the lines in a piece of research.
mm,
So the
mm,
same could happen with some of the ones that are coming through the fascia world at the moment is fascial manipulation. And it would need to be in a group where there was a group receiving something else. So that it was this group had fascial manipulation, this group had traditional myofascial release, for example, or this group had exercise-based therapy. So you're wanting to see if one has a better outcome at the end of the day, even if it's a longitudinal study over weeks and months. And the idea is not to look at the research and say, well, fascial manipulation is better. It's
mm,
better than this and this, or fascial manipulation is not, or any brand. It's about saying that there is value in that particular brand, but it might not be any better for everybody all of the time. It was only for that small group of people in that study.
mm,
And again, this is where research itself has evolved because in the last century, research was really done by Western countries and it was organized predominantly by men. And I'm way back a long time ago. So it wasn't actually looking at the population in general. And whereas now we've got studies from all over the world looking at lots of different people, lots of different ages, and we have a better understanding of whether something will be good enough to have within society and the general public or throw it out. But everything has a caveat. Absolutely everything has a caveat. A brand can be in a research study, it can be of value, but it doesn't mean it's the be all and end all because it won't suit everybody all of the time.
yeah, that's a great way to say it. There's just so many things out there now,
Yeah.
just that's the big, I think, light bulb is that you have to
Mm.
realize that it's everybody is different. There's no one size fits all on anything.
Yeah.
But
Yeah.
most importantly, I think in any of the hands-on therapeutic or even hands-off therapy is
Hmm.
is just uh, getting quiet with yourself, and taking care and just giving
Yeah.
the nervous system a little bit of a break. And one of
Mhm.
then that kind of makes me think of the polyvagal theory because it's become almost a shared language across therapy and trauma and education and even corporate wellness. I see like
Yeah.
polyvagal sessions and I'm like, what is going on? So what does it get genuinely right and where does it start to fall apart under scrutiny, particularly in light of there was a 2026 commentary
Yeah.
on the physiological claims of the polyvagal theory?
Yeah. Yeah. I think, when I look back at my training, we didn't do an awful lot in the nervous system when I did my massage training, and we were taught about pain nerves. And I suppose I really didn't think much about that until I started teaching. And then I was like, oh, wait a minute, there's no such thing as a pain nerve, it's a nociceptor. Oh, that means there's a lot of different things then that I didn't quite understand or wasn't taught. I don't remember. So when it came to the polyvagal theory, there was parts of it when I first learned about it. I thought, well, some of that makes common sense. And yes, I can see that happening in my clinical practice. I could possibly say that some of my clients are either in dorsal vagal, maybe they're in the middle, or maybe they're at the other end, or they swing from one to the other. Yeah, okay, that's a good explanation. But then when I started doing my neuroscience, and I do remember learning the pain gate theory at college. And it was simple. It was like, okay, so it opens or closes the gate to pain if you activate an A beta fiber. And that, of course, came from 1965. And then I can't remember whether it was Melzack or Wall came out and said, it wasn't accurate enough. It didn't describe enough. And we will never again think of the responsibility of pain mechanisms being in the periphery because all of a sudden, towards the end of last century, we started learning about the spinal nerves and about the complexity within the brain. So when we think of polyvagal theory, we're really only thinking about cranial nerve 10, and it goes that direction or the other direction. And it's just not that simple. It's just not. So the commentary of the 2026 spoke about areas in the brain that Porges had said was responsible for certain things according to the polyvagal theory. And the challenge that we have is that predictive processing or active inference is becoming much more mainline. And to understand the predictive processing and active inference, where the brain predicts things rather than a simple receiver, if you think of the brain as a predictor, then the polyvagal theory is just simply not enough. It's far too linear. And to say that you're either in this state or that state is just not enough. It's not enough just to put all your everything into those two places. There's far more complexity involved with it. I'm not saying that it doesn't play a role, but it's one part of many. But once you start going into active inference and getting your head around Bayesian and predictive processing, it's like you just don't think you're going to come back out in one piece.
Yeah, yeah, you kind of go down that rabbit hole and you're like, I'm
Yeah,
never coming back the same.
yeah.
I can't even think of things the same anymore. And that's also another word that I keep seeing are phrases like reset the nervous system, the
Oh, yeah,
dorsal vagal shutdown, the ventral vagal activation. It
yeah.
really sounds very clinical and precise, but you've made the case that they, again, just like what you just said, that they're not really anchored in what
Mhm.
they claim to describe. So what is that language misleading? Why is it misleading? Like what do we lose when
Yeah.
it's used loosely with clients?
It sounds like it's a little bit, when maybe not so much now, but certainly when I was growing up as a child, if the television didn't work, you'd say, oh, just pull the plug out and put it back in again. And it sounds a little bit like that. You switch it off and put it back on again. It resets it. It was like that easy peasy reset. And it just physically doesn't work like that. If it was as simple as resetting your nervous system, do you not think we would have come up with this before? Because the nervous system is never an on-off thing. It's running constantly in the background. And that allostatic load is different for every person at different times in their life. So if your allostatic load is really high, then you're going to be much more sensitive You're going to be much more aware of things going on in your body. You're going to be maybe hyperalgesia or allodynia, or you're going to be sensitive to sound and light. So it's not something really simple. There's lots of complexities make that. And it's not as simple as just switching off your nervous system and switching it back on again and see if it goes back to baseline. It just can't be done. But on the other hand, in exactly the same way as a branded technique, if you had a client who saw that you had written a blog post or a really nice Facebook post about how you can reset a client's nervous system and some little science behind it, a client's going to go, oh my God, that's me. I'm going to go and get that done. They're already going in with a positive expectation. So we're all going to have a placebo value, which means that they might have a positive outcome, even though the resetting the nervous system can't really be done. So it's a really difficult thing in our profession to just go, that's rubbish, throw it out, because it can have value for some people.
Yeah, I experienced that a lot as a practitioner when I started doing uh, um, organ work with Jean-Pierre Barral's, and somebody would invariably know about this word of fascial unwinding, and they would
Hmm.
actually come into my office ready to like hurl themselves off the table, like literally,
Yeah.
where I'm like, what the hell is this person doing? Okay, I'm gonna, you're like, hang on, all
Uh-huh.
right,
Yeah.
maybe we should put you on the floor. I don't know what's going on
Uh-huh.
with you, but like, you need some help. So it kind of threw me back, and there's this whole thing in, like, I've just always been kind of against this word fascial release. I just, when I first heard it, I was like, well, what do you mean fascia release? Like, is fascia actually releasing? And I know that there's this
Yeah.
biomechanical story, right? We talk about restricted fascia or tight tissue, or
Mhm.
we're going to release the tissue or fix the pain. It's just so tidy and perfect. But
Yeah. Yeah.
why do you think, because I know you and I meet at the same place,
Mhm.
why is fascial release just too small a story for something as complex as pain?
Gosh, that's another huge rabbit hole on its own, Sue.
We're
Um,
going to piss people off right now. I'm
oh,
sorry.
whoa, okay, right. Okay, so there was a paper came out at the end of last year. I know Quinter and Cohen are two of the authors. I think I can't remember, is it Wiseman who's the main author, the first author? 2025, it's Adieu to Amorphism is the title of the paper. And it talks about the question of nociception and pain, because I think the IASP have something along the lines that they say that nociception is not necessary for pain. But the
Right.
whole fact that it's called nociception means that it has to have a nociceptor activation. So in the paper, they write that nociception is necessary, but it's not sufficient for the experience of pain. So let's just say there's loading in the fascial system. Let's just say there is a restriction in the fascial system. The client comes in, they perceive it, they feel it, they can put their finger on it. A therapist who is trained in fascia bodywork says, oh, yeah, I've got it here, it's right here. It doesn't mean to say that that is the cause of pain, because pain requires more than just nociceptive input. It
Wait,
just, it,
is it also, I think that what I learned was that you can have you can have pain without nociception, and you can have nociception without pain. But you're saying that's not necessarily so.
that's not necessarily so. And this is again because the IASP changed in 2020. They updated their categories in 2020, and there has always been a question about not neuropathic, about nociceptive pain and nociplastic pain. If they
Right.
have a noci, which is NOx, then there needs to be nociceptor activation, but that does not necessarily mean there is pain. Because some people, do you remember the study Henry Beecher did 1950? No, it was after the war, I think, in the US, where he was treating soldiers who'd come back from the Second World War, and
Oh, yeah, where people
they
would like lose an arm. Yeah.
all
I
sorts
know
of
what you mean.
things, but they didn't need any pain medications.
Right.
And he put it down to the fact that there was a group of men together, they were resilient, they were jovial, they were encouraging each other on. So, whilst obviously, because of their injuries, nociception would have been present because of other things that they were able to do, descending modulation, top
Mhm.
down processing, beliefs, they were able to dampen that nociceptive activity.
Interesting.
So there, you can have nociception, but not actually have pain. And that's what this paper at the end of last year is actually questioning and saying we need clarity on this because I was taught in my degree, although I do, when I look back on it, we weren't in depth on it. It said that if you have bereavement or grief, you can have pain. So that's psychosomatic. But actually, if you have bereavement or grief, it will trigger, I'm using that word loosely, you can have an inflammatory response in your body because of the stress that you have from grief or bereavement. And the stress from the grief and bereavement sets up this inflammatory process, which has an effect on the nervous system in the periphery. And the nociceptors detect the chemical changes in the periphery from stress activation, and they will then initiate a response into the spinal cord and up to the brain. And as a result, the person might actually perceive pain.
Mhm.
So it's when Lorimer Moseley says pain is complex, it is very complex, but it's trying to figure out that not everybody's exactly the same. Everybody's different. You can't put the same description of what pain is from one person to the next. You have to really listen to each individual person and what's going on for them.
Yeah, I mean I mean that just makes me think like how would you say like how does the same tissue input produce such a wildly different pain
Yeah,
experience in different
yeah.
people?
Yes, exactly.
Yeah.
I was working today on some I was one of the local Scottish soccer football teams today, and I would do what generally would be called deep tissue, and I know I'm leaning into the tissue really quite firmly, but they're also know it's absolutely fine. But if I was to do that same pressure on somebody with fibromyalgia, they'd go through the roof.
Right.
So it's about nervous system sensitivity. And this was something that I think should be taught in fundamental massage programs. It's not that I wasn't taught it, it just wasn't known when I did my massage training, is
Hmm.
that the nervous system can become sensitive. It's like a dial, it can turn up or turn down. And if somebody's nervous system actually is turned up way too high, they become oversensitive. So when you lean into them to do any technique that you want to do, and they say, God, that's really sore, it's maybe not the soft tissues, it's actually their sensitized nervous system
Yeah, I
because
think
they're
that's a
perceiving
really,
it.
yeah, that's a really important concept. I can also think, of circumstances where like if I worked on two people with hand pain, one of them's a pianist and one of them's
Mhm.
a soccer player, who's going to have more sensitivity? The pianist,
Yes.
because like you're gonna ruin their career,
Yeah.
like they're
Yeah.
so stressed out emotionally
Yeah.
that like it's the same injury, right? So this whole
Mhm.
idea of the tissue being the cause of things. I mean, I think fascia plays a huge relationship with the nervous system, but by
Mhm.
far and away, I think we're like, especially on social media, it's like fascia's like the panacea in what it's doing. And I'm like, oh,
Yeah.
like we're
Yeah.
actually,
Yeah.
it's a tough thing because it's become a big buzzword. And
Yes.
so that causes I think in the real clinical world of people looking at fascia, where, you're like, no, we're taking this cellular science and we're jumping
Mhm.
too fast into the macro
Yeah.
view
Yeah.
because people
Yeah.
really just, they're not reading research. They don't really understand what they're talking
Yeah.
about. I'm like, you can simplify anything you want. And I'm a pro at metaphors and simplifying things for clients.
Mhm.
But by no means would I ever be like, oh, you know what your problem is? It's this. And I think that that's a real thing that you've
Mhm.
talked about this also this nocebo cost of how we talk to clients. And you've written
Yeah.
about how the language we
Mhm.
use could actually quietly do harm.
Yes.
Telling somebody
Yes.
that their
Yes.
tissue is stuck, their posture is pulling them out of alignment, or that their
Hmm.
body needs correction. So what's the real world nocebo cost that
Mm.
that's there, and like what's the
Yeah.
cost of that, and what does better clinical language actually sound like in a session?
Yeah, that's it's for me is one of the arguments of um saying to somebody, oh, it's a 10 session technique, or it's a 3 session, or it'll only take 90 minutes, or it'll only take so many different techniques.
Mm.
Um, because these are marketing, these are selling things. You, that can be a nocebo if you say to somebody, okay, I only need 5 techniques here. It's going to be absolutely fine. I'll sort you in 5 techniques. What if you don't? What have
Yeah.
you done to that client if you haven't actually managed that? They're going to think, oh my God, I am so broken. I'm not fixable. That immediately is leading to a stress response. And that stress response, we're going to cascade through the HPA axis. We're going to have activation of all sorts of immune signaling. And that in itself can sensitize the nervous system because of this, the connection between the different immune cells around the synaptic clefts. So
Mhm.
we have this issue of actually making the potential to make a client's pain more profound by not being considerate about our language and being considerate about how we sell things. Even if you go to social media and somebody's promoting, it's just going to be this, I can do it like this, or I have a special technique, and the client goes along and believes it, but it doesn't happen. There's a
Yeah,
problem, and
yeah.
we've got the same in education. If education, we have a responsibility of educators as educators to keep ourselves up to date. And if we're not teaching up to date material and the school is still teaching like massage detoxes the body or increases circulation or breaks up adhesions, then the client does not have the right information to make an informed decision about their own health. And then there's the trauma thing, which is even more concerning. Since COVID in the UK, because I'm the chair of the General Council for manual therapies in the UK, which is the biggest council in the UK for soft tissue hands-on work. And we are seeing a lot more courses coming through the UK, a lot of them online, claiming to treat and work with trauma. And I really think the concern there is, and a lot of them are fascia related, that
Mm.
if we're claiming to release somebody's trauma, then, and I don't know if you know the Viola Fryman, there's a few videos of Viola Fryman online. There's one where she's standing behind a guy, and Viola Fryman is supposed to be the lady who um,
Invented fascial release,
invented unwinding, isn't she? She's an
unwinding. Yeah,
osteopath,
fascial
British
unwinding. Yeah.
British lady, but did most of her work and training in the US. And she's standing behind this guy, and he's sitting on a massage table, and I think she's got her hand on his head, and she pushes
They're
him
driving
forward, and
his
it
car.
looks, yeah, he's in his car, and she says something along the words of, "We need to put him into the position he was injured in to be able to resolve it." But what happens if you've got somebody in a car accident and you're thinking, I've been trained, then I need to put this person into this position to conclude this emotional dissociation, which is said to happen in the fascial system because there's blocked energy. Maybe you could get through that, but what happens if the person's been sexually assaulted? Are you really going to put that person into the position in order to reconcile that trauma? And yeah, there's a lot of issues that, even I don't know if you've seen the Leanne Rimes one in the jaw. Have you seen
Oh
that
yeah.
one?
Oh yeah.
Not necessary. Absolutely not necessary. And it was a real, I'm going to be polite and say shame, but I could be a lot more profound with my language there. It was pretty shocking to have that video, to be fair.
I
Because
thought so
now,
too. I'm with you on that one. And I know
yeah,
now he's got a TV show, and I was a little like, wow, that's kind of
mm,
incredible. But I mean, I've done jaw releases and it doesn't look
Mm,
anything like that. It doesn't look
yeah,
it. I'm just,
yeah,
I don't even understand what that was. But
yeah,
and I think that the way that we are speaking on trauma, that I think oftentimes the clients I work on, they don't even remember the trauma that they had
yeah.
when they come in. And they're coming in because of this strain in their shoulder or the back of their body. But as the sessions move on, suddenly
Hmm.
there's this conversation that comes up. And to me, that's what sometimes therapy can do, is it calls
Yeah,
a memory back up into the
yeah.
mind. It's not coming out the body, it's coming
Hmm.
back to the brain. And maybe
Yes.
we're at an age and a place in our lives where we're ready now
Yeah.
to address that and to be heard, and to allow somebody outside
Mm-hmm.
of it to say you have every right to feel
Yeah,
this way. Right?
yeah, yeah,
Like I would
yeah.
I feel angry for you, where you're validating the reality that something
Mm-hmm.
happened. But whether or not it's the tissue, I don't know. But I would also ask you this: if hands-on work isn't releasing tissue, what is
Mm-hmm.
it doing?
I I am quite happy to say that if the client feels like a release, that's good enough for me. So I don't throw the whole term out. I came through the whole myofascial release, and I know Andre Pilat had a bit of an issue with the word release, and he changed it to myofascial induction.
Induction. Yeah, I like that.
And I remember having a conversation with Leon Chatow about it because I had gone down to a couple of workshops with when Leon was teaching in London, and we had a good conversation about it. And I said, I'm still not convinced the induction is the right thing because I'm not inducing change. The client has to come and be open to whatever happens in the treatment room. To me, it wasn't comfortable with induction either, but I don't really know what the right word would have been. But release, are we releasing something physically? I just don't see how that's possible. I think we can make short-term transient changes to tissues because of loading, but that's not just fascia, that's skin, muscles, tendons, ligaments. We can make a transient short-term change, but as soon as we unload, then that tissue is going to go back to its starting point.
Mm.
So I don't, mechanically, I don't think the release is the thing. And, Walt and I were talking about this earlier on in the week. And what is it that we perceive? Is it just the client that perceives release? But if the therapist is actually taught that what they're feeling is a release, then they will perceive that as a release.
Oh yeah.
Because I remember going to get a style of energy work called Shen, and this lady said to me, she said, "Oh, I can feel a lot of sadness leaving your body." And I'm lying there and I'm kind of doing that. Really? I don't feel that. And I thought, she's been taught that that feeling that she's feeling is that word.
Yeah.
I thought you can't, that's what you've perceived. It's not, it's my body. It's not for you to make that, lift an arm and wave it about and say, oh, there's a lot of trauma leaving your body. That's not for the therapist to see.
Oh
It
yeah.
has
I
to
mean, I've
come
I've
from the
had I've had people
client.
go, "Whoa, wow, do you feel that?" And I'm like, I don't.
Yeah.
I don't.
Yeah.
I don't know what you're feeling, but
Yeah.
but it's probably good whatever you're feeling. But I
Yeah.
I mean, I've had what's called a somato-emotional release myself. It was actually the thing that veered me out of fitness and into the healing arts was when I was
Hmm.
in the most chronic pain that I had. My body was so fatigued, and this woman, Barbara Chang, God love her, she worked on my nose, and
Hmm.
all of a sudden I went, "Oh." And she goes, "What was that?" And I said, "God, I just had this crazy memory pop back up into my head." And she asked me what it was. And I'm telling you, after I explained what it was, the next day, my pain was gone. And I thought to myself, placebo. But then it was like days went by and weeks went by, and I was like, what was that? And she said, oh, it's a
Yeah.
somato-emotional release. And that was where it really got me, where I thought, gosh, the nervous system
Mm.
really is complicated. Like was
Mhm,
that memory waiting to be reemerged? And I
mhm,
was also just in this dissection just this past week with John Sharkey, and I'm holding a female heart in my hands. And as I set it down, man, every emotion in my heart from my husband dying and not being in the room when he died, or my father dying and not being there, and having like shame and grief and anger all emerge. And then in the moment thinking, God, I hope that when my mother dies, I'm holding her hand,
yeah,
right? But
yeah,
like, what is that? I don't have an answer for anybody. It's just, it's kind of the letting go of some aspect of our spirit
mhm,
that
mhm, mhm,
we sometimes lose touch with because we almost become too human, and we forget that somewhere maybe this form is just something we occupy for a time, and then when we leave there is something else. I
mhm,
don't know if that's true, but
yeah,
I like to think that there's if energy is not created or destroyed, then I always was. It's just in this moment I'm Sue Hitzman, and I got a podcast. You know what I mean? Like
yeah,
it's
yeah,
like
yeah.
yeah, I don't know
It
what
is.
to say.
And I think for me that leads into to body work. I was taught to release the fascia. Now, I don't think I'm releasing fascia, but if that's what my client perceives. But
Okay.
what I do think I'm doing is I am giving the tissue, the skin. By the way, there's 250 million sensory receptors in skin,
Yeah.
according to the book, Grunwald's book, not just fascia. And if we're touching skin, if we're then communicating through the skin to the underlying tissues, I'm providing sensory input.
That's
And
it.
if we can do the techniques that attract the different mechanoreceptors, like some like shear, some like vibration, some like long sustain, some like deeper pressure, if we can employ the techniques that talk to all of those mechanoreceptors, bring the client's awareness into that at the same time. Say, can you feel my hands? What does it feel like? Tell me what you're noticing. And we've got a good environment for them. We're helping them perceive their body differently.
Yeah.
And what you're describing, the holding the heart. My mum passed away last year, and we're going through the process of clearing out the house and selling it. And it's been really challenging for me because my life was still at my mum's. My two sisters married and moved away and took all their stuff with them over 30 years ago. I've gone backwards and forwards to my mum a lot for various different reasons. So all my childhood stuff was still there. So I'm having to empty my childhood stuff, then my mum's stuff. And I'm bringing it here and I'm having memories of where did I get that? What did I have this for? I'll sell that on eBay. I'll make some money. All of these things I'm going through, but I'm remembering some really fantastic memories and ones that are not so great. But I'm the age I am now, with the understanding I am now, and I do have a different perception of that experience.
Yeah.
And I do think that's what we do in body work. We help a client experience their body differently.
Yeah, I
So
always
we
think
do
that
it.
what we're doing is kind of creating an interruption in the story.
Yeah.
Kind of we
And
put a
that's
bookmark
called an
somewhere.
error. That's your prediction error. So that comes from predictive processing.
Yeah.
So if a person, for example, if a person is standing and they have back pain, and you ask them to do a simple assessment, can you bend over and touch your toes? Immediately they say, no, that's going to be sore. I'm not doing it. So the prediction of pain is stopping them move. So it's
Right.
a fear of movement. But if you were to put your hand on their low back, give them a sensory input, can you feel my hand? Do you feel the warmth of my hand? Tap your fingers. You're giving them a different sensory input that they might be more willing to bend just a little bit. And if we can create enough prediction error, then we can change the perception.
Yeah.
And to
Yeah.
me, that's what we do with our hands. It's not releasing, it's actually creating a prediction error.
What do
Yeah.
you think about people? This is another word that drives me bananas is when people are breaking up adhesions.
Oh,
And I'm like,
yeah.
look, look, sometimes people do. I have worked on scars that literally you could just put a little bit of traction on and actually feel all the way around the other side of the body tissue tension that should not happen. And so in those cases for pathology, I
Mhm.
do believe that there's adhesions are real. I've seen them in dissections. But But these people who are like, oh yeah, I just released an adhesion in my neck. And I'm like, did you really? Like, what is that? Like, if touch isn't, breaking up adhesions or releasing fascia, like what is it doing when it actually helps, right?
Yeah, I know that phrase breaking up anything is just why would you want to do that? Why would you want to break anything? But I usually think of the Chowdhury paper from 2008, 2009 about that talked about the load that is required to actually break anything up is just way past what we could employ with our hands.
Yeah.
And then you've got the one that's thrown out as the £2,000 per square inch from Kitaki, 1961. Oh, fascia can exert up to £2,000 per square inch. That's why you have pain. And I think a lot of people misunderstand that because the paper is about the bursting of fascia. So they take, I think it's the crurofascia, the fascia lata, I can't remember the other line. There's three pieces of fascia they put it in clamps, they load it until it bursts and it rips apart and it's £2,000. It's not that it's £2,000 per square inch of pressure on the body. It takes £2,000 to burst it apart. So you can't, how you, there's no way. That's the equivalent of like over 60 suitcases standing on a pound coin.
Right.
We just can't employ that 23 times 60 odd suitcases. It's just impossible for us to
Yeah.
break anything up. And it's putting that into context. So what am I doing if somebody has a scar? I actually wonder that we're not really influencing the scar because the scar tissue is firmer and more dense than the surrounding tissues, even though it's about 80% less resilient. And it's less resilient because of the surrounding structures. So it doesn't stretch the same. But I wonder, are we actually doing more to the tissue around the scar than the actual scar? So as Susan Chappell says, we are attenuating the scar. And I think that's a really nice way to put it. We're not breaking anything up or releasing anything, we're attenuating the tissue. So we're creating less influence of the scar on the surrounding tissue. So I do
Mm.
wonder if that's a better way to describe it.
I like that one. And I also think about there's the Carey study that was the paper kind of pointed towards the care built around the safety and
Yeah,
communication and the collaboration, like all the relational stuff.
yeah.
So for therapists maybe trained in technique heavy traditions that
Mm,
can feel like a little bit of a demotion, I think. So how do you help therapists see that shift as a clinical upgrade, not a watering
yeah.
down of what they
That,
know?
that's a that's a hard one. Because if we're saying, let's just say, if we are saying that a high percentage of the patient-reported outcome measures, because a therapeutic outcome actually doesn't involve the technique. The therapeutic outcome is literally the client therapist interaction, the contextual factors, placebo belief, etc. But if we are saying that a high percentage does not involve the technique, then why do we all go to massage school? What's the point? Why go and do an osteopathic degree if all you need to do is just, as the phrase, I think it came from Canada, touch people nicely? It's not a phrase I would use in the UK, touching people nicely, because that really has the wrong connotation, by the way.
Really does.
And I wouldn't use it. But I
Wouldn't use it.
understand what they mean. I do
Yeah,
understand what they
I do too.
mean.
Yeah.
So it's difficult when a therapist. I've done this qual because in the UK we have like a level three is a school leaver certificate in massage. Then you can want to do a level four. So level three, you don't really work on pathological tissue. You're providing a sports massage for wellness or relaxation massage, therapeutic massage. Then you go on to do a level four, and that allows you to treat injuries. Level five allows you to do more rehab and critical evaluation of an injury. So somebody always wants the better techniques. I want to go and do this course to get that technique and this course to do that technique. And I'm saying, actually, see the techniques you already have. Let's just adapt them. Let's just perfect them because
Yeah.
they are really, really good. You don't need to go and learn that technique over there. It's going to cost you £500 because the ones you've got work really well.
Yeah. And
And
now you've
that's
got this.
hard.
Yeah. I mean, it is. And I think that there's just so many techniques out there. I think it's
Mhm.
hard for any of us to be like, you'll never, I always say I'll never have enough time to learn
Yeah.
all of the things that I would love to learn. But, coming and taking people's courses, I think has been very valuable for me over a
Mm.
lifetime, is just always thinking a little out of the box and never being certain about anything. And you've got this new book, A Massage Therapist's Guide to Pain, Touch, and Perception.
Mm.
And that kind of lands right in the middle of all of this. So for a
Mm.
therapist listening right now who feels the ground is maybe a little shifting under everything that they were taught,
Yeah.
what, like everything that we just talked about, what is the first move forward? Tell them a little bit about the book and the hands-on therapy workshops that you've
Yeah.
got.
Yeah. I was asked a long time ago, actually just before I started my degree, Handspring asked me to write a book, and I started doing it. It was called Fascia and Pain. That's what the book was going to be called. And then I finished my degree and I went, I can't write a book about fascia and pain. That just won't work. I literally had to go, oh, well, let's start again. And I thought, we're not taught enough about pain. And for me, the biggest shift in my hands-on career was I had always questioned unwinding because I came through hypnotherapy before I did my fascia release, and I saw the unwinding happen in hypnotherapy. I also saw it in the evangelical church. So I thought, it's not really a myofascial thing. Well, it might be a fascia thing, but it's not a myofascial. It's not a response to MFR solely. So I had lots of questions, and I thought, one of the biggest things that really made me, I guess, move forward in my thinking was that simple thing, nociception and pain are not the same thing.
Yeah.
So I wanted to write a book to help therapists understand why it's not as simple as releasing somebody's pain or treating the biceps brachii because they've got pain in their arm or low back pain. Oh, it only takes a certain amount of techniques and I'll fix your low back pain, because that's just not how it works. So the first part of the book discusses a little bit about history of pain. I've based it around Louis Gifford's mature organisms model. And I asked permission from the late Louis Gifford's wife to be able to use this model. So it talks about the input into the central nervous system and how the brain samples and scrutinizes that information and then provides an output. So it's this circular route that's constantly going input, sample, scrutinization, output the whole way around. So I talk about what is input, and the input comes in the form of the nociceptive, neuropathic, and then for me, the most interesting category is the nociplastic category from IASP. So I go through what are nociceptors, what do they look like? Are they myelinated? Are they not myelinated? Is the pain gate theory enough? And then I talk about the categories from IASP and focusing on musculoskeletal pain and nociplastic pain, talking about what happens in the periphery, what happens in the spinal cord, what is descending modulation. And then I go in and I talk about the brain networks. So there's the central executive network, the salience network, the default mode network, how these work together, and how there's no such thing as a reptilian brain. It was a lovely story that was made up, but it actually doesn't work that way because the brain is so complex. It's not a receiver, it's a predictor. And if you understand the prediction capability of the brain, you can see how when a threat is detected, when the brain predicts a threat, it will cascade down into the body the sense of fear and trauma and anxiety, which our interoception picks up. And then it changes the whole concept of the mind and the body, or pain lives in the body, or trauma lives in the body, because you're understanding it's a prediction from the brain. And the brain, of course, is the nervous system. And then I've got a little bit on unwinding. I've got a chapter on unwinding, breaking it down, why I think the descriptions that are out there are not good enough. Looking at it from a predictive processing perspective, looking at a lot of the discussion from Bessel van der Kolk, because he does not mention fascia anywhere in The Body Keeps the Score. A little bit about Peter Levine's book, Waking the Tiger, why I think we can use things as metaphors, where I think don't think things are accurate enough. It's not that they're wrong, they're just not enough. And then the value of movement unwinding versus hands-on touch unwinding. What can it be used for? Is it behavioral inhibition? Is it idiomotor responses rather than trauma leaving the body? And then at the very end, I bring it all together and I've got something called the integrated touch hypothesis, which I'm suggesting is what's happening with us as creating prediction errors with our hands when we do manual therapy, how the brain processes that, how it updates its learning, how we can add that to descending modulation, endogenous opioids, all of the things coming down from the brain into the body to change a perception that helps a person move through a pain response and manage their pain. So that's kind of what it's all about.
Wow. I cannot wait to read this book, Ruth. I mean, first of all, just thank you. This is exactly the kind of conversation our profession needs more of. It's very generous, you're very rigorous, and I think you're really
Yeah,
willing to sit with complexity instead of selling certainty. And I think that we need more
yeah.
of that.
And I think that was a big point for me, Sue, because we don't have enough books in our profession. Because I'm not claiming to have it right. I want to make that absolutely clear. And I say this at the beginning of the book. I'm just taking it from my perspective. The whole point is to be able to create curiosity. But I have put a lot of references. That was one of the stipulations I had with Handspring. There has to be references in this book to every part. So at first there was 10,000 words of references. And I've tried to keep the references as up to date as I possibly can. There's some seminal papers in it, but I've even got a paper, as I mentioned, the Adeutomorphisms 2025.
Yeah.
So that to me is important.
Well, there's going to be more research and we're going to discover more and more things. So, I'm sure that you'll make a second and third edition like many of our
Mhm.
cohorts because there's always something more to learn. So, Ruth, I
Yeah.
ask everybody the same question on Anatomical Gangster to end the show. So, I'm going to pose it to you. If you could tell somebody something that you've learned in your lifetime, a real life lesson, something that completely rocked your world, completely changed your view of the human experience, and if they heard it, they might change their mind too, what would it be?
Be willing to accept uncertainty. That
Beautiful.
was a big one for me because and I mentioned this at the beginning of the book, I was taught and I feel like I was really good at working out somebody's problem. I was really good at looking at somebody's pelvic balance. Okay, it's the ASAS is down lower in the right than it is in the left. Your lumbar is doing a type 1 when it should be a type 2. All of that, I was really good at it. But that was the way I explained how somebody's pain was, because that's the way I was brought through the profession, because that's where the profession was at that time. And I'm the same as hundreds, thousands of other therapists. But in actual fact, if you can accept uncertainty, be able to say to a client, do you know what? You've got one leg longer than the other. It's functional. It doesn't mean that it's the cause of your pain. It's okay. But if I can help you feel more comfortable in your body, that's what I want to do for you today.
Yeah, beautiful. I mean, I hope that that's what every therapist is
Mhm.
there to do is just help somebody through whatever it is they're dealing with. Well, for everybody who is listening to this, if this cracks something open in you, grab Ruth's book. Again, it's called A Massage Therapist Guide to
Right.
Pain,
Yeah.
Touch, and Perception. And if
Yeah.
you're a therapist who wants to spend a weekend thinking really hard with other people who care this much, I want you to check out her integrated hands-on therapy workshops in
Mhm.
Glasgow in August, Bristol in October, and
Yeah.
London in November. And I'm going to make sure that I put the links in the show notes. So if this
Thank you.
episode hit, share it with a therapist, with one
Yeah.
client, with one human who'd benefit from clear thinking about touch, pain, and the actual work we do for one another. And again,
Yeah.
please subscribe to this podcast so that you don't miss what's coming next. And remember, the body is more interesting than
Mhm.
any single explanation we have for it. So stay curious, stay grounded, stay a little gangster, and we'll see you next week. Thanks for joining in. Thank you, Ruth, for everything.
You're welcome. Thanks for asking.